This meeting is being recorded.
Good afternoon, everyone. My name is Dominic. I'm with Ghana Medical Help. We thank you for joining us for our maternity service agenda. This week, we looking at a high yield topic, mostly for midwives and all of us as doctors in maternity, and anyone who has maternity and safe delivery at heart. The Partograph, the good old Partograph, still very essential. And I'm sure our presenters today, being supervised by Dr. Caesar Wombro, a specialist obstetrician gynecologist at the Tamal Teaching Hospital, and Dr. Benjamin Lawson, a resident at the Obstetrics and Gynecology Department of TTH as well. Over the last month, that was in May, we put a pause on our weekly presentations because we had emergency obstetrics and neonatal care training in the upper regions, that's the upper east and the upper west. So a couple of our trainers who are now trainers would be joining us for this meeting as well. The plan of that was it took the form of a train-the-trainer model, or what we call a TOT, so that then in the various districts, these midwives and doctors who were trained and given some equipment can then do the training on hospital basis. We are hoping that with the continuation of this program, those and the practical training as well ongoing, will be able to contribute in our own little ways towards the improvement of maternity service delivery in northern Ghana, with emphasis on the upper east and then the upper west. We are grateful that you are joining us today. Just some few household rules. Immediately the presenter starts, you realize that you will be unable to unmute yourself because I will turn off the unmute button so that then nobody would inadvertently unmute and then probably distract the presenter whilst the presentation is ongoing. However, the chat box is available throughout the presentation, such that if you cannot wait to have your question said at the end of the presentation, or you may forget about your question, you could use the chat box to put this in so that at the end of the presentation, we can have a discussion. And like we always do, the presentations are meant to be quite brief to allow us some time to have some bit of a discussion. So we are envisioning a 30-minute presentation and then some few minutes for questions and answers. If, of course, we are not able to address everything, we can always plan another day so that then we are concise, straight to the point, and then people still have their Fridays open. So without much ado, I would want to welcome Dr. Benjamin Lawson and then Dr. Caesar Womboro. So over to you, Dr. Caesar, if you can take us do the brief introduction, and then Dr. Lawson will do the presentation. Thank you very much.
Thank you, and good afternoon to all our audience. I am Dr. Anson Awomboro Caesar, and I'm a specialist OBGYN at the Tamal Teaching Hospital. And today's discussion is on Partograph. And Partograph, as we all know, is a very essential tool that is used to monitor labor, to help us pick up problems, to intervene appropriately, including referral, so as to be able to get good outcomes for both the mother and then the baby. It's also a tool that, if adequately used and timely used, would help judicious management of the labor process, as well as that of the outcome documentation of the delivery. Now, this tool has gone through several phases of changes, and we now currently have the latest WHO care guide, which is yet to be adopted by most hospitals. So we would go through a brief history, go through the various photographs that we have to the current ones, We'll touch on it briefly, won't go so deep into it because most institutions have not yet adopted it. We are still using the modified WHO Partograph. So I would invite Dr. Lawson to take us through the Partograph, and I would encourage everyone to participate so that at the end of it all, we go home informed. Thank you. Dr. Lawson, over.
Yeah. Good afternoon, everyone. My name is Dr. Lawson, and I'll be presenting on the Partograph. This is the outline of my presentation. So the definition, the Partograph or the labor graph is a one-page simple chart for graphically displaying key information about how labor is progressing and the condition of mother and fetus during labor. It is also a tool that gives early warning signs of abnormal progress and assists in early decision-making and triggers timely institution of appropriate, predetermined, specific preventive and treatment intervention in accordance with standard management protocols of labor to prevent prolonged labor and its complications. Therefore, the Partograph is an essential tool for decision-making, like my senior colleague said, and prompt appropriate interventions to prevent and treat labor complications. So a brief history of the Partograph. So in the 1954, Friedman introduced the concept of a partograph, and this concept was derived from plotting cervical dilatation against time in hours. So in plotting, like you can see on the diagram, this you can see a sigmoid curve, which is called the Friedman curve or the labor curve. So Friedman introduced this concept and plotted it against cervical dilatation against time in hours. So he obtained a sigmoid curve known as the Friedman curve. So you could see that Friedman divided labor into two parts, the latent phase, active phase. And then he further divided the active phase into the acceleration phase, the phase of maximum slope, and then the deceleration phase. So you can see an example of the Friedman's partograph, which is also known as the composite partograph. So it has two phases of labor, latent phase at a cervical dilatation of less than 3 cm, then an active phase, cervical dilatation of greater than 3 cm. So the partograph was further modified by the Philpott and Castle in 1972. They introduced the concept of alert line and then the action line. The alert line, which was drawn on the 4 cm dilatation, alert line that was drawn on a 3 cm dilatation to 10 cm, and then at a rate of cervical dilatation of 1 cm per hour. And then the action line, which was 4 hours to the right of and parallel to the alert line. They also plotted the descent of the head, fetal head as well. So in 1969, Hendricks et al. Also demonstrated that in active phase of labor and the rate of dilatation of the cervix in primary gravid and multipara varies just a little. And then there is no deceleration phase at the end of the first stage like Friedman stipulated. So in 1987, the WHO introduced the WHO composite partograph. And in this partograph, you can see on the left side of the screen, you could see that the latent phase it's made up, it has a latent phase which was 8 hours duration. The active phase could see the alert line drawn from 3 cm to 10 cm at a rate of 1 cm per hour. And then you could also see the action line as well. Then in 2000, the year 2000, WHO modified the composite partograph into the WHO modified partograph, which you can see on the right side of the screen. So for that one, the latent phase was excluded and then the active phase started at 4 cm cervical dilatation. And then in 2020, the WHO introduced the WHO Labor Care Guide, which is composed of 7 sections. You have the maternal biodata section. Let me see if I can get a picture of. Okay, it has a maternal biodata section, pregnancy history, supportive care, baby section, section of the mother, the labor progress, medication, shared decision making, or the plan after your assessment. So the similarities between the modified WHO Partograph and the labor care guide. You see that it's a graphical representation of the progress of labor in terms of the woman's cervical dilatation and the descent of the fetal presenting parts against time. You see that the same thing could also be seen in the modified WHO Partograph. And then the second similarity is the formal, regular recording of important clinical parameters describing the well-being of the woman and the fetus. Okay, so this is a picture of the modified WHO Partograph on the left and then the labor care guide on the right side. So, like my senior colleague said, it hasn't been fully adopted in the country yet. Yeah. So with the differences for the modified WHO Partograph, you could see that the active phase defined as starting from the 4 cm of cervical dilatation, while for the labor care guide, the active phase defined as starting from 5 cm of the cervical dilatation. And then on the modified partograph, you have a fixed alert line, which is at a cervical dilatation at 1 cm per hour and an action line 4 hours apart. But for the labor care guide, it has an evidence-based time limit at each centimeter of cervical dilatation. For the modified WHO partograph, there is no second stage section, but for the labor care guide, it has an intensive monitoring at the second stage. The modified WHO partograph has no recording of supportive care interventions, but for the labor care guide, it has explicit recording of labor companionship, pain relief, oral fluid intake, and then the posture. For the modified WHO, we have it records the strength, duration, and the frequency of the uterine contractions, while the labor care guide records duration, frequency, and the uterine contractions. And then for the last difference is there is no explicit requirement to respond to deviations from expected observations of any labor parameter other than the cervical dilatation, alerts, and action lines. But for the labor care guide, it requires deviations to be highlighted and then corresponding response to be recorded by the health provider. And then there are also other parthographs, the handwritten one on a paper and a pencil, the one partograph, and then the e-partograph. So we'll talk of the objectives of a partograph. So one of the objectives of a partograph is that it can detect early abnormalities. There is an early detection of abnormal progress of labor. It prevents prolonged labor. It can recognize cephalopelvic disproportion long before obstructed labor, and it assists in early decision on referral, augmentation, or termination of the labor. It also increases the quality and regularity of all observations of mother and fetus. Early recognition of maternal or fetal problems. It's highly effective in reducing complications from prolonged labor for the mother and for the newborn as well. It also reduces incidence of CS rates and then facilitates handing over procedure. So the components of the partograph, we'll be using the modified WHO partograph. So it's in parts. For the first part, you have the patient identification. Second part is the fetal well-being. Third part, progress of labor. Fourth part being the maternal well-being, and then the outcome. So you could see on the screen the various parts, and I'll further elaborate. So for the first part, the patient identification, you have the name, the gravidity, the parity, the hospital number of the patient, date and time of admission, and then the time of ruptured membranes. And the second part has to do with the well-being. So for the fetal well-being, it's used to monitor and then assess the fetal well-being by checking the fetal heart rate. So on the screen, you could see that you have small boxes. So on the horizontal axis and then the vertical axis. So the horizontal axis, it's the time, and then the vertical axis is the beats per minute. So each box on the vertical axis is 10 beats per minute, while on the horizontal axis, each small box is 30 minutes. So the fetal heart rate is checked every 30 minutes and then plotted on the partograph. The normal fetal heart rate is between 120 to 160 beats per minute. So once you check your fetal heart rate, then you plot on the partograph by drawing a dot on the fetal heart rate. And then, so every 30 minutes, you check the fetal heart rate. So the first fetal heart rate was around 120, and the next 30 minutes around 130, and then the next 30 minutes was around 130. So after you've now created those dots, you now join the dots together. And then the next thing to assess is the state of the membranes and then the color of the liquor. So for the state of the membranes, during your vaginal examination, which is done every 4 hours, so you do your V, then you check the state of the membranes. If the membranes is intact, you indicate by writing I. And then if the membranes is ruptured and then the liquor is clear, you indicate by C. And that one is also done every 30 minutes. And if the membranes is blasting, you indicate B. And if the membrane is absent, you indicate A. And then if the membrane is meconium, the liquor membrane is ruptured and the liquor is meconium stain, you indicate with an M. And then the next assessment will be the molding of the fetal skull. So the molding is also assessed through the vaginal examination, which is also done every 4 hours. So first of all, you do your V, then you assess to palpate the fetal skull. And then you palpate and then you identify the sutures, so the parietal suture. And then you also assess how the two parietal bones are placed. So in checking the molding, if the parietal bones are apart and the sutures are easily felt, then you indicate 0. Then if the parietal bones touch each other, you indicate a 1 plus. And then when you do the assessment and the parietal bone overlaps but reducible, you indicate 2 pluses. And then if you check your the molding, your assessment, and then the parietal bones overlap but are not reducible, you indicate 3 plus, and it can also be classified into first degree, second, third degree molding. Okay, so this is what I just explained. With the 0, you could see that the sutures are easily felt and the parietal bones are apart. You could see it from what I just explained. So the third part is the progress of labor, which is assessed by cervical dilatation, descent of the fetal head, and then the uterine contraction. So you could see from this cervicogram that, and then also the progress of the cervical dilation is assessed by doing your VA, which is every 4 hours. So when you do your VA and then you assess the cervical dilatation, then you come and then plot it on the Partograph. So from this cervicogram, you could see that the patient, and then the cervical dilatation, it's against time. So you have your y-axis and then the x-axis. The x-axis or the vertical axis has the time, and then the horizontal axis has the cervical dilatation. And then on that same uh, horizontal axis, you have the descent of the head as well. So from this diagram, you see that the patient's cervical dilatation was 4 cm. Sorry. So cervical dilatation, during assessment, cervical dilatation was 4 cm, and then you write an X on the cervical dilatation in 4 cm, and then you circle it. Then for the descent is done by the abdominal palpation. So when you palpate the abdomen, then you assess the descent in fifth. So first of all, you determine by doing your pelvic grip in the leading part of the head has entered, to check if the head has entered the pelvis. And then you identify the anterior shoulder and place the finger of the left hand to mark its location. Then you place your palm on the right hand on the abdomen with the little finger touching the top border of the symphysis pubis. So when you do that and all the head is in the abdomen, and the head of the fetus takes all 5 fingers to cover the head in the abdomen, then it's 5/5. And then if it takes 4 fingers to cover the head, then it's 4/5. And then if it takes 3 fingers to cover the head, it's 3/5. So forth and so on and so forth. So this, I have a picture of what I was explaining here. So once you assess the descent of the head, you now come and then plot it on the Partograph. And in this case, you indicate that with a small circle. So in this cervicogram, you could see that the descent was at 3/5, and then us at 7 a.m. So at 7 a.m., V was done. The patient cervical dilatation was 4 cm. Descent was 3/5. Then in the next 2 hours, the descent was checked again, and it was 2/5. And then the next 2 hours, that was around 10 a.m., it was 0/5. And then for the cervical dilatation, the first assessment was done and the cervical dilatation was 4 cm. And in the next 4 hours, it got to 10 cm. So this is an example of a normal labor. And then with the uterine contractions are checked every 30 minutes, and assessed every 30 minutes by palpating the abdomen. So, and then it's uterine contractions are assessed per every 10 minutes. So in this example, you could see that if the box, you have a vertical box and then the horizontal box. The horizontal axis, it's against its time, and then the vertical axis is the uterine contraction. So the vertical axis, one box, the vertical axis is one contraction, and then one box on the horizontal axis, it's 30 minutes. So that's 10 minutes, sorry. So you could see that from this diagram, the first contraction, you had one contraction, and then the contraction lasted less than 20 seconds. So if the contraction lasts less than 20 seconds, you indicate it with by shading the box with dots. And then if the contraction lasts between 20 to 40 seconds, which is a moderate contractions, you draw a diagonal lines in the box. And then when the contraction lasts more than 40 seconds, you shade the entire box. So in this diagram, first, listen, we had a one contraction which was lasting less than 20 seconds. The next one was also one lasting less than 20 seconds. And then we had two contractions in 10 minutes that was lasting between 20 to 40 seconds. And then we had the last listen that we had was about five contractions lasting more than 40 seconds, which is an adequate uterine contraction. This is what I already explained. So the next component is the maternal well-being, and that is assessed regularly by monitoring the oxytocin, and then the amount per volume in IV fluids in drops per minute every 30 minutes. Then other drugs that are given, then also the IV fluids used, then the pulse as well. So the pulse is assessed every 30 minutes and marked with a dot. I'll show you a diagram of it. And then the blood pressure is recorded in vertical lines every 4 hours and marked with arrows. The temperature is recorded every 2 hours. And then we measure and record volume and test for protein, glucose, and acetone every 2 hours. So, like I said, so the pulse, here you have the drugs given and then IV fluids at the upper part of this section. And then, so if you give any form of fluids, IV fluids, Ringer's lactate or normal saline, you indicate it there and the volume of what you give. And then for the BP, like I explained, this assessed every 4 hours with an arrow, with the upper parts being the systolic and then the lower part of the arrow being the diastolic. And then the pulse is assessed every 30 minutes. And then it's indicated on the partograph with a dot. And temperature and then urine output is also assessed. So we'll move to the advantages of a partograph. So one of the advantages is that the partograph is inexpensive technology which does not malfunction. It's a single sheet of paper that can provide details of necessary information at a glance. It helps in continuity of care and providing information on the labor. And then there is no major capital investment other than skilled attendants. It also documents, it's a documented evidence for medical legal purposes and also an educational value for all grades of staff in the facility. And some of the disadvantages that it assumes that all women progress at the same rate, which may influence intervention rates. And the clinical findings have subjective variation. Someone can do a VE, say it's 4 cm, you can also go and check and do, and then your estimation is 5 cm. So there can be variations in your clinical findings as well. And then there is also loss of clinical autonomy. There is another disadvantage is that there is there is lack of knowledge in the interpreting and then plotting of the partograph, and then non-availability of printed partograph, especially in resource deprived facilities. And then also there's can be duplication of the recording. So we move to the management of labor using a partograph. So if you plot the partograph and the plotting is between the alert and then the action line. Okay, first of all, what you do is if you are in a health center, and then the patient must be referred to a hospital with facilities for cesarean section unless the cervix is almost fully dilated. You can also observe the labor progress for short period before the patient is referred. And then you can also continue routine observations by assessing the fetal well-being, maternal well-being, and then the progress of labor. And then you can also do an ARM. ARM may be performed if the membranes are still intact, and then the prolonged labor, maybe let's say the prolonged labor is due to inadequate uterine contractions. You can do an ARM and then augment the labor as well if there are no contraindications. And also, if you plot the Partograph and it's at or beyond the action line, yeah, you need to conduct a systematic assessment of the patient to determine the cause of the poor progress in labor. Considering you can also consider intravenous infusion, bladder catheterization, or analgesia. So the poor progress could be due to where you have your three P's. Could be the patient, passage, or the passenger. So in this case, if it's the patient, it could be from maternal exhaustion. Can give you IV fluids, empty the bladder, and give analgesia as well. And then you have options of delivery by delivering via cesarean section if there is fetal distress or cephalopelvic disproportion. And then also you can augment with oxytocin by intravenous infusion if there are no contraindications as well. So we have a case scenario. So we'll go through this case scenario to see how we can plot this on the Partograph. So Mrs. S, gravida 3 para 2 plus 0, was admitted to the labor ward at 9 a.m. with a fetal heart rate of, on assessment, the fetal heart rate was 130 beats per minute. Amniotic fluid was clear. Skull bones are just touching each other. The fetal head is 3/5 palpable. Cervix dilated 5 cm. She was having 4 contractions in 10 minutes, each lasting 35 seconds. BP was 120, 80 millimeters mercury. Pulse was 80 beats per minute. Temperature 36.8. Volume of urine was 200 mL. And then at 11 a.m., fetal head descent was 2/5 palpable. 4 contractions in 10 minutes, each lasting 45 seconds. And at the 1 p.m., fetal heart rate was 140 beats per minute. Amniotic fluid is clear. Switches were overlapping and not separated easily. Fetal head is 0/5 palpable. Cervical dilatation progressed at rate of 1 cm per hour. And then she was having 5 contractions in 10 minutes. BP was 120/80, pulse 90. And then she had a spontaneous vaginal delivery at 1:20 p.m. So I don't know if the Partograph is clear enough for you to see. So the case scenario was just a normal labor. So Madam S, gravida 3 para 2 plus 0 with a hospital number of 7886 was admitted on the 12th May 2000. Time of admission was 9 a.m. So at 9 a.m., when V was done, she was 5 cm dilated. So you could see that an X was drawn on the 5 cm, and then the descent was 3/5, like we could see from the screen. And at the same time, 9 a.m., the fetal heart rate recorded was 120 beats per minute. And then the amniotic fluid, they assessed, the membrane was assessed, V done, a membrane was assessed, membrane was ruptured with a clear amniotic fluid. You could see at the amniotic fluid section that a C has been written there. And then there was no molding at that time. And the contractions were also 4 in 10, lasting more than 40 seconds. So she had adequate uterine contractions. And then the BP, we read from the case scenario, BP was around 110, 70. pulse was 80 beats per minute, temperature 38.6.8 degrees Celsius, and then the urine output was 200 mils. So that was what was recorded from the case scenario that we read at 9 a.m. And then at 1, I think at 1 p.m., another VE was done, and then she was 10 cm dilated. So you could see that the cervical dilatation was on the alert line, meaning that she was having the cervical dilatation at a rate of 1 cm per hour. Then the descent that was assessed after the 4 hours was 0 fifth. And then as at 2:20, she delivered a live female infant with 2.850 grams. That's the outcome of the delivery. So with this, you could see that we were able to plot the labor progression on the partograph that is on the screen here from the case scenario that we got. And then, so this is a partograph of a normal labor. At least I would have made this more interactive if like everyone had a partograph, then we all plot and discuss, but I don't think it's possible. So another case scenario, this is a case of cephalopelvic disproportion, a CPD. See that Madam Mrs. H, gravida 4 para 3 plus 0, was admitted on the 20th May 2000 at 10 a.m. So the partograph was started at 10 a.m. like you could see from the screen with an X with a cervical dilatation at 4 cm. And then the descent was 3 fifth. And then the FH on assessment of the fetal well-being, the fetal heart rate was 140 beats per minute. And then the amniotic fluid was clear. So as you can see, that it's denoted with C, and then there was a molding 1 plus on VA assessment. And then the contractions in 10 minutes, as at 10 a.m. when she arrived, she had three contractions that was in 10 minutes, lasting between 20 to 40 seconds. And then the BP was 120/70, pulse was 80 beats per minute. And then the temperature was 36.8 degrees Celsius. So the next assessment, well, that was 4 hours later, that was at 2 p.m. You could see from the partograph that she progressed. She moved from 4 cm to 6 cm cervical dilatation, and then the descent moved from 3 fifth. She repeated the same descent, that was 3 fifth, and she was also having adequate uterine contractions as well. So there was 3 contractions in 10 minutes that was lasting more than 40 seconds. And then the V down the molding was 2 pluses. The amniotic fluid was clear. So in this case, you could see that the plotting of the partograph has moved. It's beyond the alert line, meaning that this woman is not progressing well. So the V was repeated again in 4 hours, and she still had the same cervical dilatation. She repeated the same cervical dilatation at 6 cm with a descent of 3 fifth, even despite adequate uterine contraction. So with this, you could see that the woman was not progressing well. And then so a decision was made to section on account of, I think, a CPD. So the outcome was that she had a live male infant that weighed 4.6. So we could see that it's due to CPD, because which is caused by fetal microsomia. So in this case, the partograph was able to help to detect the poor progress of labor, and then a decision was made to do a cesarean section. And then the next partograph is a case of a prolonged active phase. So with this, you could see that the patient was admitted to the labor ward at 10 a.m. And at 10 a.m. upon assessment, the fetal heart was 140 beats per minute. The membranes were intact. Cervical dilatation was 5 cm and was 4 cm, sorry. And then the descent was 5/5. Uterine contractions, she was having two uterine contractions in 10 minutes, which was inadequate. It was lasting less than 20 seconds. And then the BP was 110, 70 beats per minute. So in this case, the patient was reassessed after 4 hours. She still repeated the same cervical dilatation and also the descent as well. And then you could see that the clotting was to the right of the alert line. And then this was also due to inadequate uterine contraction. So they also assessed the patient in the next 4 hours again and realized that she only, the cervical dilatation increased from 4 cm to 6 cm, and the descent was still 5 feet. So you could see that it's a case of an arrest uh, descent of the head of the fetus. So a decision was made to section this woman at and the outcome was a live female infant with a weight of 2.650 grams. Thank you very much. So any questions, suggestions, or welcome.
Thank you very much, Dr. Lawson, for a brilliant presentation. I would want to make some few inputs where in scenarios where you have twin gestation, you can still use a partograph. And in such cases, you would want to use different colored pens, either red or black or blue, to plot the individual twin A with one unique pen and then twin B with another unique colored pen. So it is not a contraindication to use partograph in cases of twin gestation. Secondly, whenever you put a on a partograph and a decision is made to deliver the baby abdominally, VCS, if there is any delay in delivering the woman whilst the patient is still at the labor ward, it's prudent to still be plotting the fetal heart rate on the partograph until the woman is sent into the theater. And then application of the partograph, you need to understand that every patient who comes from the labor ward has to be individualized. The care has to be individualized based on your history. And so patients would not require augmentation if they are contracting adequately. And the partograph is explaining what adequate contractions meant. So that it's not the case that everyone who comes should be put on a partograph and automatically needs to be augmented. No, let's individualize the care. Then another important part is closing the partograph. Most often, many of us do not close the partograph. How did the labor end? You need to tell us it ended in a spontaneous vaginal delivery or a cesarean section, whether it's an emergency or not. And then the outcome, and then the condition of both baby and mother. The partograph, when you turn the back, is usually plain. You can write additional notes on the back of the partograph, and you can attach that to your referral sheet or even use that as a referral to a few things I would have added on. The floor is open to questions at this moment. Any questions, contributions to the presentation given so far? Madam Bridget, please, you can unmute and ask your question.
Okay, thank you. Good evening to everyone. Please, I want some clarifications. The first one is with the state of the LICA. I realized on one of the photographs, it was plotted every 30
Please
minutes.
unmute and ask your question. I've seen two hands up, either Madam Bridget or Madam Mary.
Please, this is Madam Bridget talking. Hello?
Yeah, so I think Dr. Caesar's line may be delayed. Bridget, kindly go ahead.
Okay. So my question is with one of the photographs, I realized that the state of the LICA was plotted every 30 minutes. I want to know, is it because it was ruptured and it was clear? That is why it's plotted every 30 minutes? Or whether or not it's ruptured, you still have to plot it every 30 minutes? Thank you.
Great. So whilst we wait for Dr. Benjamin and Dr. Caesar to probably answer those ones, I just want to draw your attention to the fact that I've put up some two charts right in the chat box. One is about our handles on social media that you can click into know our presentations. The second one is for those of us who want the PowerPoint presentation, as well as the recording of today's Zoom meeting. You can click in to provide answers to the survey and then provide your email so that this can be sent to you. Just so you take a look in the chat box. And then, because I've seen a couple of questions in there asking about the recording and also asking about the PowerPoint presentations, just click on the kilometrics link that I've put in there, provide answers to the survey, provide your email, and these will be sent to you. Thank you so much. Yeah, so Dr. Benjamin, Dr. Caesar, kindly address the question. Thanks.
Yeah. So the accessed every 4 hours during V. So after doing your V assessment, you just indicate, but then you could see that you have spaces left in between, so you can just fill in those spaces with a C. because from the time of assessment to the next assessment 4 hours, the LICOR was clear. So the LICOR will change on your next assessment. So from that moment, that first assessment to your next assessment, I think you can indicate or record C in the column to fill up that column. I don't know if the C also has something to add to it. Hello.
Good afternoon to you all. Please, my question is about the time. Because I realized on the Partograph, well, let's say the woman came today, you write today's date, and your first VE, the woman wasn't in active phase. So are we supposed to write the time your next VE will tell you she's either 4 cm or she's in active phase, or you are going to write the time she reported to the facility with the reporting date?
Yeah, hello. Okay, so
Hello?
thank you for your question. So we all know that the Partograph is started when the woman is in the active phase, which is 4 cm. That dilation. So when she's in the latent phase, since you not started, you put the time that she was 4 cm on the Partograph as the time of admission, because that's the time you admit the patient to the labor ward when the patient is in active phase of labor. Hello?
Hello.
Yeah, hello.
Hi, please ask your question.
Hello? Hello?
Hello.
Yes, please ask your
Yeah, hello. Are you clear?
question.
Hello?
I think the network isn't too good.
Hello?
Hello, Dominic.
Hello?
Yeah, I think my network has been. Hey guys, hear me?
Yes, we can hear you.
Yeah, we can hear you now.
Oh, great. All right. Good now. That's good. Yeah, I think I see a couple of messages about the telecell network issues today. That's fine. But once
Hello?
Yeah,
we are
hello.
recording
Please.
it, like issues like me, and you can always go through it when you have a stable network. I see Regina wants to talk. Regina, please go ahead and talk. Regina, you've muted yourself.
Yeah, hello. Good evening.
Good evening.
Yeah, please. My question is, what's the ideal time to rapture memories?
Yeah, so Dr. Caesar and Dr. Lawson, she's asking about the ideal time to have the membranes ruptured. I don't know if you guys can hear me. It just looks like score. Can anyone hear me? Or can? Okay, so whilst we wait, I don't know. Can anyone hear me? Any of those who are like host or co-host, Dr. Howard, yeah. Anyone who can hear me? I don't know if I'm just talking to myself. Yes, okay, someone has sent a message. Yeah. Yeah, so Regina, when any of the panelists has an answer to your question, I'm sure they will mute and go ahead and provide an answer with it. I don't know what the ideal time is myself, so I can provide an answer to that.
Hello?
So, yeah, hi. Yeah, so.
Yes, so I was saying there, so if you want to actively manage the labor at 4 centimeters dilatation.
Oh, great. Okay. Yeah, so Regina, there you have it. All right. So I was just creating an awareness that I've put up a link in the chat box, which I'm going to do again, so that then if you had network issues like me today, you can have the recording sent to you. When you click on that link that I've just put up now, and then provide your details, and then we can have that sent over to you. I see people putting email addresses in the chat directly to me. I'll not be able to send it to your email address unless you use the link that I've put in. At the end of it, you find that there's a request for your email address, and then we can have that sent over to you. As well, the social media handles that I put up, which I'm going to put up again just right now. The last one is the YouTube handle. It will also be posted there as well, so you can have access to it. I've just put that up. So number 2, you realize that's the link, the YouTube handle. When you click on that and you subscribe to the channel, you have those videos as well. I hope that addresses a couple of the questions in the chat box regards those who had network issues and those who dropped off during the presentation. Okay, so I see 2 hands up. I will just ask you to unmute yourself, and then you can make your contribution since we still have about some minutes. Yeah. Nicola, please go ahead.
Okay, good evening, sir. Yeah, please, I have 3 questions. One is on the patient profile, the column whereby patient comes and their membranes is already ruptured, where it is indicated the hours. Instances whereby the person ruptured an hour 30 minutes before coming or stepping into the facility. How are you supposed to write it? And my second question too is specifically on the maternal section. You said if the mother is if the woman is experiencing maternal exhaustion, you can give intravenous fluid to the person. And I saw analgesia. So I want to find out what analgesia specifically are you supposed to administer to the person? And my last question is, what contraindicates Partograph? What is the contraindications for Partograph? Thank you.
Okay, Dr. Lawson, you go.
Yeah, hello. So with the time of rupture of membranes, there's a column for that. So if the patient ruptured membranes in 1 hour 20 minutes, you write it in that column. The membranes ruptured 1 hour 20 minutes. Hello? Hello?
Yes, can you hear me?
Hello?
Yeah, we can hear you.
Yeah, hello?
Yes.
Yeah, Lawson, go ahead.
Yeah, Lawson, can you hear us?
Yeah, hello?
Yes, we can hear you loud and clear. Please go.
Okay. So I was talking about the time of membrane that the membranes were ruptured. You said, let's say, if the patient's membrane was ruptured in 1 hour 20 minutes, there's a column for that. So you just indicate it in that column. Thank you.
Yeah, great.
Yeah, hello?
Yeah, we got that. Thank you. Yeah, Nicola, I see that your hand is still up. Let me ask if you have any further.
Please, I asked 3 questions and he answered one. And when you take the Partograph, for instance, what I'm saying is that 1 hour 20 minutes, but that column is only written hour in an hour. So are you supposed to write the 1 hour 20 minutes in that particular section? And my second question was on the maternal section. Like he spoke about maybe if the woman is experiencing maternal exhaustion, they're supposed to give intravenous fluid and then analgesia. So I wanted to find out the particular analgesics that you are supposed to administer. And my last question was on what contraindicates Partograph? Like what are some of the contraindications that you will not maybe use the Partograph? So that is my last question. Thank you.
All right, great. So you had a couple of questions. Yeah, so Dr. Lawson, Dr. Caesar, any comments on that? Answers to any questions? Yeah, Dr. Caesar, will you want to take that? Yeah, I don't know if you guys can hear me. I can't hear anything like from presenters. Yeah, so whilst we wait on them, I'm sure probably if they have the answers, they will talk on them. If anyone as well in the team wants to answer to those questions, feel free to unmute yourself and go ahead. Yeah, hi, go ahead, Lawson.
Can you hear me?
Yes, please go ahead.
Yeah, so the number of hours the patient ruptured before you are administering the person on the Partograph, you would write the number of hours and minutes in that column provided. Although they said hours, if you have hours and minutes, you put it in there. It's just for us to know when to start antibiotics because of prolonged either term or preterm rupture of membranes. So that is what that portion is supposed to indicate. Now, the second question about patients' analgesia of choice. So there are various methods. Most often we'll go in for the pharmacologic methods, such as petidine. We can give petidine, IM petidine, between 50 to 100 milligram. We either add promethazine or metoclopramide. They give a synergistic effect and potentiates the action of the analgesia. Most often we would not want to give it when the woman is about 7 centimeters dilated because the petidine's half-life is about 2 to 3 hours. If you give it after 6 cm, what it means is that baby might be a bit floppy when baby comes out. That is just one analgesia of choice, which we can have at a district level or any rural area. But the gold standard analgesia is the epidural anesthesia that we usually would give to pregnant women. So epidural is a gold standard. So if you have it, you can give epidural as well. There are other non-pharmacologic methods of relieving pain during labor, which can be explored. The third question, if I heard clearly, was on contraindications for, putting a patient on Partograph. So if the person is not in active phase, you will not put the patient on Partograph. If the person is fully dilated, you won't put the person on Partograph. If it's an IUFG, you don't need to put a person on a Partograph. If you have slated a person for yes. So I think these are some of the contraindications. Yeah.
All right, great, fantastic. Okay, yeah, so I don't see any hand up. I think we've gone beyond the 1 hour. So we want to say a big thank you to Dr. Caesar and Dr. Lawson for an excellent job done. It was a great presentation. I get a couple of messages from the chat box as well, saying how good the presentation was. There are a couple of questions which are in the chat box. Unfortunately, I'm not sure we can address all of them. I see a hand up. Okay, the person has dropped his hand. So that we keep to the time and as we advertise as well. And definitely the Partograph is something we'll really look at again. There were even suggestions during our meeting that we let one of the head midwives also lead the presentation on the Partograph, because they, of course, have been using it as their bread and butter, so that the language is same at that level as well. So it's something that we'll definitely relook at as well. So all these questions will also be answered when that comes on. So we are grateful to you all for joining us today. We are glad that we'll be able to impact knowledge. I learned a lot myself, and I'm sure you did. Next week, we would have another presentation. We'll share the details on our Facebook page, like I've put in the chat box. So if you like that page, you will have that, or our LinkedIn account, same as well. And then the video, like I mentioned, for those of us who had terrible networks today, is on, would be put on our YouTube handle when that is available. So we're so much grateful that you made time to join us. Hopefully we meet again next week. I would quickly allow those two hands which I have to hear briefly what they have to say, and then Dr. Caesar can close us off as the specialist for today. So first is Dr. Salam Husan Puenta. Please go ahead and make your contribution, Dr. Salam.
All right. Thank you very much, Dr. Lawson, for the presentation. I initially left the question on the chat box thinking you read it, boss, but since you did that, so I want to ask. It's in this line. Looking at the WHO recommend that Partograph, or let me say active phase, should start at 5 cm, and that was far back 2018. And the Obstetric Care Consensus Committee, which comprises ACOG and the Society of Fetal Maternal Medicine, sometime 2019 also recommend that active phase should start at 6 cm. What is the reason for our slow, or should I say lack of pace in adapting this new recommendation?
Yeah, great. So I would call on any of either Dr. Lawson or Dr. Caesar to see if they have answers to your question. Otherwise, any of the panelists can also go ahead and do that. All right, so whilst we wait on that, we can have the second question from Adams. Aminatu, please go ahead, unmute yourself and have your question asked. I've asked you to unmute yourself, Adams Aminatu, or it was done in error, the hand. Okay, so let's, Dr. Caesar, will you want to respond to his question, or Dr. Lawson, then of you to Dr. Salam's question?
Do you mind repeating the question? I didn't get it.
Yeah, Dr. Salam, will you want to unmute yourself and go ahead? Yeah.
So the question is, I'm saying as far back as 2018, WHO recommend that active phase should start at 8 cm. And somewhere 2019, the Obstetric Care Consensus Committee, which comprises of ACOG and Society of Fetal Maternal Medicine, recommend that we should start Partograph at 6 cm. I'm saying, what is the lack of, or let me say, absent pace in adapting these new recommendations in our obstetric practice?
Yeah, so when a policy change or policies are drafted, you know that it goes through a policy cycle and it comes with logistics. So Ghana Health Service, to the best of my knowledge, although have accepted the WHO and then the care guideline, haven't started ruling out nationwide others, but even within Polygo, modified WHO one. So it's a matter of policy, and until the nation decides to go in that direction, individual institutions cannot unilaterally start using them. So we just would use them for educational purposes, for you to know that they are newer tools that are on the market, and you should know about it, such that when it's finally adapted, you can fall in line. It's purely a policy matter. So I personally don't even know of any hospital within where I work that uses the new care guide.
All right, great. Yeah, Salam. So are you okay, or you have another question? I still see your hand up, or is a legacy hand?
What is a legacy hand? Thank you.
All right, great. Adam Saminatu, your hand is still up, or is also done in error, like I was asking? Okay, so no response from Adam Saminatu. Then the last hand is from Abdullah Mohammed S. Please go ahead and unmute yourself and then make your contribution.
All right, thank you very much for this presentation. I think it's a very wonderful presentation. I really enjoy it. Spare me my ignorance. I want to know something small. Photograph is always something that we learn every day. I want to know the time interval in recording the BP on the photograph chart. That's my first question. Then the second question, when you are monitoring a client on a photograph, yes, we have the alert and the action line. So if it happens that your photograph crosses the action line, do you still have to buy time after you have used your photograph correctly? Thank you.
All right, thank you, Mohammed. So Dr. Caesar, Dr. Lawson, any response to his questions? Hi guys, Dr. Lawson, Dr. Caesar, any of you can hear me? I don't know if it's from my end, Dr. Caesar, you seem to be cutting off.
Interval of chatting, right? And if I'm right, blood pressure whilst the maternal pulse is every 2 hours. Hello?
Yeah, it's clear
Hello,
now.
can you hear me? Yes, I said the blood pressure is monitored every 4 hours.
Great.
And the second question was, when you bypass the alert line, what do you do? So usually, if you bypass the alert line, you want to reevaluate to see whether the reason for your progress of labor being to the right side of the alert line. I mean the alert line. So you want to reevaluate why is labor moving towards the action line. You reevaluate if depending on where you find yourself. If you are in the district or in a rural area, once you cross your alert line, it tells you to reevaluate. If you find the cause, maybe she's not contracting well and you can augment, you do that and reevaluate. If not, it's time to start preparing the woman to refer. And whilst referring, you continue your resuscitation till the person gets to the referral center. So usually once you hit the alert line, you want to reevaluate and see whether certain measures can be taken to improve the labor progress.
Great. Thank you so much, Dr. Caesar. I think that was the last one, and we've definitely gone beyond the time. Yeah, Mohammed, do you have a follow-up?
Yes, hello, Doc.
Yes, sir.
Yeah, Mohammed, so you've muted yourself again. Kindly unmute and go ahead.
Okay, thank you. I think I was actually referring to the action line, not the alert. I don't know whether doctor get me right. I was referring to the action line. So in the case you have monitored the case, she has crossed the action line. Is there the need to still buy time in the facility? Maybe I'm using the hospital for instance. Is there the need to still buy more time? Maybe like some doctors ask you to add some 2 hours, or maybe is it in a good faith? That's what I just wanted.
Dr. Lawson, move to your last Partograph slides, one of them, so that I use that to explain. Now, when you are within, when you are on the Partograph, monitoring on the Partograph, you have to ask yourself, when you started plotting at the 4 centimeter dilatation or on the alert line, this is a good Partograph. You watch the point of contractions. You realize that in this very case, the woman had inadequate contraction, but no appropriate intervention was instituted for the client. So if I come and I see that the patient has purely been having inadequate contractions without intervention, the fetal heart rate is fine, maternal vitals, everything is fine, and the patient has crossed the action line, what I would usually do is that I would institute the appropriate measure by augmenting appropriately, and then giving her maximum 4 hours to see, 2 to 4 hours to see whether the person's dilatation or progress of labor improves. If it improves, you want to monitor till delivery. But where you have done appropriate interventions and the person still crosses the action line, you need to refer if you are in a peripheral facility. And if you are in a facility that can operate, you need to evaluate, find your cause, and then deliver the person if you think the person has a poor progress secondary to either a malposition or CPD or obstructed labor, depending on where you find yourself.
Yeah, great. So I guess Mohammed is fine. He's dropped his hand. All right, great. Dr. Taki, Ian, your hand is up. Please go ahead.
Yes. Good evening, everyone.
Good evening.
And thank you very much for this program. I just wanted to add my little voice to the discussion.
Great.
All right. So, in fact, concerning this last Partograph, I think it was an example of a bad Partograph. So, I thought the presenter would have made a comment on it. I mean, things were not going on well, and we are not sure why the patient had a cesarean section, whether it was for the inadequate contractions or not. So as what's his name, the one who just explained said, I mean, there should have been some form of intervention, I mean, way back, even before the patient crossed the action line, because it was clear from the contractions that there was a problem, right? Then also to comment on the LICO color, the color of the LICO and the frequency of it, how it's checked. Yes, I think that you check it every 30 minutes when it is ruptured, but you don't do it by vaginal examinations. You know, when the when the membrane structure, you place a pad, and so every 30 minutes you do a vulvar pad inspection to check the liquor color. So that's how it is done. Because obviously we want to avoid doing a lot of vaginal examination. And I think the presenter mentioned something like that. So just to correct that part. And as well, also to re-emphasize what the panelists also talked about, the labor care guide and the other discussions, because obviously these are policy things. And in fact, the labor care guide hasn't been rolled out. So it is not a matter of slow pickup. It's not been rolled out. So you cannot use it in your own place. Yes, thank you very much. I think these are my comments.
Thank you, Dr. I.M. Taki.
Great. Yeah, so I think that's it for now. Thank you, Dr. Aaron, for increasing the depth of the knowledge out there with your comments as well. And we are grateful, Dr. Benjamin Lawson, for the presentation. It's been great. We've learned a lot. Dr. Caesar, thank you for supervising and serving as the specialist for this presentation. We are grateful to you as well. And to all those who have joined us for today, we are glad that you made it an interesting webinar. It was quite interactive, unfortunately, because we had to eat beyond our 1 hour that we usually would give, but of course, it's for good reasons. It's the Partograph, and it is important that we get to it. And like I did mention, because of course, the significance of it and the fact that we also want the language to be at the level of the midwives as well, we're looking at one of the midwives who would volunteer to do this as well in subsequent meetings. And like I mentioned, it's the same link that we use every week, Friday, 3 to 4 p.m. If you even forget to look up our social media handles on the topic, but you just remember that 3 p.m. on Friday, you have a date, an hour to join in a discussion. You can just hit the same link that you used today, and you'll be at the right place. So we're so grateful to you. God bless you all for the wonderful participants and discussions that we have had. We're hoping to that we can draw the curtains for today. Thank you. Dr. Ben. All right. So thank you guys, and have a wonderful weekend. Bye-bye.